Morning, everyone. I want to thank you for coming in this morning and welcome you all to the webinar that's being provided here by the state regarding Maryland local care teams and state agency policy, specifically for policies for youth with intensive needs in hospital settings. Next slide. So my name is Jennifer Crabill. I am the Chief of Strategic Initiatives here at the Governor's Office of Crime Prevention, Youth and Victim Services. The Governor's Office of Crime Prevention, Youth and Victim Services, we are the successor to the Governor's Office for Children. We also chair the Youth Resource Coordinating Council, which is an interagency body that's looking at the continued coordination of state and local resources for youth with intensive needs. We also administer local care team coordinator funding that comes from the Children's Cabinet Interagency Fund. We provide assistance to local care teams, technical assistance to local care teams, and we are today's facilitator. Next slide, please. We wanted to bring everyone together today, and initially this was focused directly at hospitals and frontline staff that are seeing these youth come into their care and struggling to find placement or struggling to find a discharge plan. And we have put together the Children's Cabinet in our office, which is an interagency effort. We've put together coordination with other state agencies as well as the local representatives to really make this issue a priority to ensure that all relevant stakeholders are available to assist with services when youth enter a hospital. The goal for today is to expand your understanding and knowledge of the partner agencies on the local care team. And through an understanding of what resources and opportunities are available, then collaborative efforts can be more effective. Next slide. The first thing here today is just to talk about local care teams. What are local care teams and what agencies sit on local care teams? So you're going to see a local care team in every single jurisdiction. Every local care team also has a coordinator. As I indicated before, that coordinator is funded by the Children's Cabinet Interagency Fund. Local Department of Social Services has a representative, Department of Juvenile Services, the local school system, local management board, parent or parent advocate, local division of rehabilitation services, Department of Health, and then your local behavioral health authority / core service agency. As some of you may or may not know, within the local behavioral health authority, different counties are structured a little bit differently in how those LBHAs are how they're structured. So one county may have a local behavioral health authority that sits within it, their core service agency dealing with those behavioral health services, as well as the local addictions authority. And then some counties still have those agencies that are separated out. But that representative does sit on the local care team. So I just also want to make it clear with regard to local care teams that these representatives that sit at the local care team are assigned by their local agency, and may or may not be the person that would be the case manager or the lead for any individual case coming forward. These are your local experts that are sitting at the table together and brainstorming, how do we create a care plan for this youth and family? What resources are available? Next slide. So the next question we hear a lot about is, well, what do local care teams do? What is their role? This slide is very helpful in that we wanted to make sure that everyone understood what local care teams do and what they don't do. So local care teams are there to provide a forum for children and families with intensive behavioral health needs. So they are an interagency group, and they are there to provide a forum. They are very interactive, and the assistance participation of the youth and families are extremely important with regard to local care teams. They provide interagency problem solving to identify those individual needs and potential resources for the family and the youth. They also refer children and families to care management entities or available local and community resources. And when I say they refer children and family, the local care team coordinators do not necessarily make those referrals. It is the agency that has been identified as having those resources and the plan that's put together that then moves forward and takes care of that referral process. Local care teams identify and share resource development needs. We'll go through this a little bit later, but local care teams provide data to local management boards, and they provide data also at the state level. So we're constantly working on developing resources and looking at what we need and where we need it. And they are also required under statute to discuss a request for a voluntary placement agreement. Now, we want to make clear that local care teams do not make VPA decisions, but they are there to discuss a VPA to see if there are any other options or available choices for the family. But those VPA decisions, those are made directly with the Department of Human Services, Social Services Administration. Local care teams do not make placement decisions. They do not make treatment decisions, and they do not make placement referrals, approve out-of-state placements. Think about this as a forum and a way to create a care plan to then send out to the agencies or the applicable agencies that could provide service to this family. Next slide. Okay. Next thing, what is the role of a local care team coordinator? We've often had questions about local care team coordinators as well. Local care team coordinators, they're administrative staff, and they facilitate the local care team process of interagency case management. They are not case managers, and they're not crisis response staff. So their duties are performed during regular office hours. The funding comes from, it's awarded to local management boards, and it comes from the child placing agencies through the Children's Cabinet Interagency Fund. So the Department of Human Services, Juvenile Services, Health, and the Maryland State Department of Education, they all contribute and fund local care team coordinators. The staff support to the local care teams is designed to ensure youth with intensive needs that they receive comprehensive support services. Local care team coordinators, they must ensure that a coordinated system for local care team case referral and tracking is in place. Okay, so they maintain a comprehensive resource database, they collect data, and they ensure follow-up services are in place. And that's a part of that case plan that they put together when the referrals and the reviews are done. Staff are responsible for facilitating a coordinated approach to services and ensure parent involvement. So parent involvement, again, family involvement, very important in local care team. Requirements for a coordinator. The requirements right now that the Children's Cabinet have put out indicates that the position requires an individual that has experience with child placement systems, a clinical and or special education background, and a master's degree in related fields. So these are folks that have a history and experience with child placement systems, as well as a master's degree. Their general responsibilities, they have administrative functions, they manage the local care team meeting operations, and they also are responsible for outcome measurement. So essentially they report data on performance measures. They also are in charge of implementing the Universal Hospital Discharge Planning Protocol. Next slide. So the goals for the discharge planning protocol. So all hospitals, and when this was developed, the Hospital Association in partnership with the state agencies developed this discharge planning protocol and really recognize that local care teams are a single point of entry for youth in acute hospital settings. Again, a reminder that local care teams are voluntary, participation in them is voluntary. So consent should be sought from a parent as a part of that discharge planning process. The planning protocol is also meant to promote increased collaboration with hospitals. We want to make sure that communication and collaboration is there. And that hopefully, the goal is to then increase timely and effective coordinated discharge planning. Next slide. So we have some expectations of the partners in the process. And when you talk about who are the partners in the process, this first slide here really talks about the hospitals and what we have for expectations in the hospitals. Hospitals acknowledge that local care teams are the first point of contact if the protocol conditions are met. And again, we'll give you links and everything to those protocols. If the conditions are met, then the hospital discharge planner or the designee, whoever that may be, would complete the local care team referral and send it electronically to the local care team coordinator in the youth's county of residence. That's super important, right? Because if you're in a hospital, it does not go to the local care team where the hospital is located, it goes to the jurisdiction where the youth is from, because those are the folks that will know resources and available resources when the youth is being discharged. The referral should also contain hospital discharge recommendations and psychosocial summaries. Let me be clear, the referral as it sits now, it's very lengthy. So the expectation is to fill out as much as that is applicable and to get the relevant information over to that local care team coordinator who can then follow up. So next slide. We expect of the local care team coordinators. We have right now directive number 3, which came out from the Children's Cabinet. And that directive describes the process once that universal form is received. Contact with the family is to be made within 72 hours of receipt, and simultaneously the coordinator should be notifying the applicable agency designees and setting up a meeting with the local care team and hospital staff within 5 days. So something I didn't mention on the last slide is it's very important when these referrals are received that hospital staff participate in those initial local care team meetings so that all of the information can be disseminated. Because of the time frame that we have put on this, it's most likely the meetings are going to be held virtually, and they're not going to include every member of the local care team, and that's due to that shortened time frame. Hospital staff are really going to be key for these meetings. And also, every attempt to include families should also be made by local care team coordinators and the hospital staff. In these situations, not everyone can attend so quickly. So keeping the family informed is really important and paramount. During and after the meetings, local care team coordinators, they're expected to keep careful notes that outline the care plans and agency commitments to ensure follow-up services as necessary. Now, having talked to you about the responsibilities of the coordinator, I have to say, if you read Directive 3, it specifically states that if a youth has an open case with a local care team participating agency, that agency will assume the lead role in coordinating services and care for the youth. So local care team coordinators, they're responsible for maintaining a collaborative approach, but they're not asked or they're expected to assume the role of a case manager, and they don't intervene and rectify case progress when an action plan may fall short. So during team meetings that you go to, if you are a hospital frontline staff, take that opportunity, familiarize yourself with the mandated members, maintain direct lines of contact and communication so that you can do that when issues arise. And local care team coordinators, they're going to be able to link you and link parties together for discussion. And that's really the job of the local care team coordinators. Again, this facilitation and coordination. Next slide. So the resources here, the Children's Cabinet page on our website has the universal referral form It has the directive, the hospital discharge planning protocol, and also the local care team directory. We'll make sure that all of these resources go out to you. This webinar is being recorded, so we will be able to post this and send you a copy of the slides as well, so that you can have links to all these things. Next slide. Now, if there are any questions or concerns, you can contact myself or Chris Mealy. Chris was unable to be here today. He's actually, he is in DC at a conference. So, but Chris is the policy analyst in our office that's responsible for providing technical assistance to local care teams and local care team coordinators. So Chris is really the person who's going to be able to facilitate any kind of questions or concerns that come up with regard to this process. But as always, I am available. I have a couple of minutes here, and I'll see if there are any questions in the chat. Okay. First thing I'm seeing is a question indicating that are the services available for people with private insurance? Yes, send that referral over to the local care team. There is no requirement, insurance requirement. I will say obviously that the services or the case plan would be impacted by what is or is not available for private insurance. But no, local care teams, absolutely. If a youth and a family, it has intensive behavioral health needs, the referral can go over. Next question, does that mean caregivers / legally authorized representatives are not required to attend for an LCT to occur? So we don't have a necessary requirement, especially on the hospital referrals, that the initial meeting is done within 5 days. However, caregivers or those legally authorized, they would be treated the same as family members. If folks are involved in the care and ongoing treatment of the youth, we want to make sure that they're involved in the process. Another question regarding CEUs, I do not know the answer to that, but I certainly will look into it, and we will get back and have a post on that. Okay, well, thank you all. We're going to move along. And the next presenter here is going to be Caroline Jones, and I'll let Caroline take it over here and introduce herself to the group. Caroline?
All righty. Good morning, everyone. I'm struggling with my voice this morning. I don't know if it's allergies or what, but my name is Caroline Jones, and I am with the Behavioral Health Administration. I am the Director of School Age Programming. The Behavioral Health Administration is a department within the Maryland Department of Health. So of course, Maryland Department of Health is very large, and then we're a department within there, and we work solely with youth. Our division works with youth who have mental health needs in the community. So we focus on youth who have who are part of the public behavioral health system. As you see here, this is just our mission, and we are very sincere about promoting recovery, resilience, and wellness for individuals. Next slide. So this is our vision, which we created a couple of years ago. In all of our objectives, we want to make sure that our resilience and prevention, that were very oriented, that was self-directed. A big part of our goals are very integrated and very community-based focus. We do a lot of work. All of our collaboration is done with our local jurisdictions, and I'll talk a little bit more about that as we go along today. Next slide. So the Behavioral Health Administration, we do a lot with collaboration with partners. So we work with the local behavioral health authorities. We will work with Department of Juvenile Services, Department of Social Services, MSDE, and the governor's office. I don't know, Jen, the long name, so I'm not going to go into all of that. But the Behavioral Health Administration is a smaller unit. So in terms of the local care teams, the local behavioral health authorities or the core service agency in each jurisdiction will have a representative that sits on the local care teams. And those objectives are to provide an overview. Today, we'll just provide an overview of the role and what they do on a local care team, and then how to access the local behavioral health authority and the core service agencies in your jurisdiction. So at the end, there's a link to the MABA, which is the organization that the local behavioral health authorities belong to. Next slide. So I talked a little bit already that the Behavioral Health Authority is, the Behavioral Health Administration is under the Maryland Department of Health. And then within each jurisdiction and community, there is a local behavioral health authority. The local behavioral health authorities are under the departments of health in their jurisdictions. We also have the core service agencies, which are usually privately run in their jurisdiction. So most jurisdictions have local behavioral health authorities, but we do have 5 that are just core service agencies, but they are all under and members of the Maryland Association of Behavioral Health Authorities, which is MABA. And they provide and collaborate, partners, sit on the local care teams in their own jurisdictions. They also work with the local addictions authorities, which also are part of the departments of health in the jurisdictions. And the goal is to also work with individual licensed behavioral health providers in their jurisdictions as well. Next slide. So what is a local behavioral health authority? A local behavioral health authority, as I talked a little bit, is responsible for managing grant funds for behavioral health services in their jurisdiction. And they also help manage services or refer youth for services, especially those youth that are need services from the public behavioral health system. The public behavioral health system are the services that are under our administrative service organization. And later on in the slides, I will give you a rundown of services that are available for children and youth that kids that are enrolled in the public behavioral health system can access. Next slide. So the roles and responsibilities for our partners from the local behavioral health authority and the core service agencies that sit on the local care team are to ensure access to a full range of quality behavioral health services. Each jurisdiction will have some very different funding because of the way we utilize grants, some federal funds, some state funds, and not all of the services are always available in each jurisdiction. But what is important is that you reach out to the local behavioral health authority in your jurisdiction, and they are experts on knowing the services that are available. So they can advocate for parents or children, but their role in the LCT is to assist parents that may need any services that come to that particular team. Next slide. So they can, an LCT, they can provide specific insight related to behavioral health needs for a youth. So it does not have to be a youth that is, the focus is for youth with, that has been enrolled in the behavioral health, public behavioral health system, but they can assist with making referrals for youth who may have some private insurance for targeted case management plus services, which is a service for youth who have private insurance. It's a short-term service, and we provide some case management services to the individual in the community. And those youth are able to get some customized goods and services and some peer supports that may be available to them. They also are able to provide case-specific recommendations at that table. I just talked about care coordination. There may be a youth who is not familiar. They can refer them to outpatient mental health services, partial hospitalization programs, whatever may be available in their jurisdictions. They can also connect folks with the appropriate behavioral health system providers in their jurisdictions. And one of the things they also do is follow up on complaints with specific behavioral health providers in their jurisdictions, and they work with us and let us know, some of those things, following up complaints from beginning to end. Next slide. So here is a list of current public behavioral health services that are available to youth who are eligible. So there is outpatient mental health services, there's targeted case management, and those are 3 levels of services. So depending on the intensity of need, you can get a level of service starting from just basic services, which would be a lower level of need, to targeted case management level 3, which are more intensity focused services. And once the youth would be eligible for those, then based on financial eligibility, they could enroll in 1915I services. Those 1915I services will give you additional intensity needs. Of course, these services are available for youth that are enrolled in the public behavioral health system. So yes, those are Medicaid youth. We do have PRP programs in the community. There's intensive outpatient programs, respite. There's ABA through Medicaid for youth that are needing those type of services. Mobile treatment services, TBS, and eventually RTC, but that of course is a process. And RTC, access to RTC, your local behavioral health authority representative that sits at the local care team can help an individual access an RTC level of care. Next slide. So that is pretty much how the local care team works for the local behavioral health authority person role. I don't actually sit on local care teams, since we do have all those individuals in each jurisdiction. They sit on the local care teams, and they are the experts that have the resources available in their community. They are a member of the Maryland Association of Behavioral Health Authorities, so I provide the link here for you there. And then there is a directory that gives you each individual contact in each jurisdiction of the local behavioral health authority and core service agencies in those jurisdictions. And that is, I think that's it for me. I think the next slide just has my contact information on it.
So Caroline, we had a quick question
Okay.
in the chat in terms of how quickly can these services be accessed? Are there waiting lists for these services?
So for the public behavioral health services, those can be accessed pretty quickly. You just need to go on and you would be able to, I'm not quite sure, the application process is not long. For targeted case management, it's just reaching out to the care coordination organization, and then they can be enrolled. It doesn't take that long to access the services.
So another question is, Laura says she was thinking the same thing. Can parents access these resources independently, and how would they go about doing so? So, for example, you don't need do you need a hospital to reach out to these services? And if they need assistance in navigating or help, how would they do that? Parents independently.
So they could access them independently by reaching out to the ASO website. Our current ASO is Optum, and you could reach out. They have Optum Maryland, I think .org is their address, and each on that website, it does give you description of the services that are available, and the parents can reach out. They do have an individual that they can reach out to that could help them navigate that.
I would say also your
they can also, it's really important to, if they are struggling, the local behavioral health authority, again, they're just wonderful partners, and I just suggest that people start with their local behavioral health authority as well, because they can always point them in the right direction to access the services. We have a lot of partners out there.
Yeah, and I can also say some of the Maryland Coalition of Families has been a great resource as well. To help families. So individual parents can access Maryland Coalition of Families, and they will help they will help navigate as well for individual parents and families that might need access to some services. So Maryland Coalition of Families, local behavioral health authorities, reach out to the parents can do that. And then I have another question, Caroline.
I think someone said, how do you reach the CSAs? You can, the website that I gave you, the Maryland Behavioral Health.org, you can go there, and there is a directory that gives all of the contact information for each local behavioral health authority and or core service agency in your jurisdiction. And it has numbers that you're able to call, and they will direct you to the child and adolescent coordinator or whatever person you need in that jurisdiction.
Okay, and Caroline, another question is from Michael. Did I understand correctly that people with private insurance can get some support?
Yes, we do have targeted case management plus services. And the great part about that is that we just increased those slots. So those available to youth who are in school and need some additional behavioral health services. As you said, the Maryland Coalition for Families provide our peer support to those youth, and our CCOs, the care coordination organizations, will provide services to the youth for, like I said, it's for a 6-month period. It can be reevaluated after 6 months, but they can reach out to our local behavioral health authorities. They can also reach out to our CCOs to apply for targeted case management plus services. We have our slots have been increased to 75. And we do have openings right now. Yesterday, there were only 58 youth enrolled. So we have openings that are available to youth that have private insurance. And it's called Targeted Case Management Plus.
Okay, I think that answers Paula's question about some TCM, what's available for youth with private insurance. We also have from Paula, is BHA engaged in advocating for and getting improved mental health parity of services for private insurance families?
I think that they have started to have those kind of conversations, as far as I have been told, but I have not been at the table for those discussions, but I think that they have been through the hospital associations, maybe possibly having those conversations.
Okay.
Okay.
Thanks, Caroline. That
Sure.
looks like it's it for you. I know, and I'm seeing a couple of other questions in the chat that sort of will apply to what I talked about earlier. So I'm going to hold off on those. I know Danielle put one in, and I believe Latia. So I want to make sure I do have eyes on those questions. So we will try to get to those, but I want to keep us moving here and keep us on time. So the next presentation is from Sheila Phillip with the MSDE, and I will let Sheila go ahead and introduce herself and take it over.
Thank you, Jenny. Good morning, everyone. As Jenny said, my name is Sheila Phillip, and I'm the Section Chief for Non-Public Special Education here in the Maryland State Department of Education, often referred to as MSDE. And I work within the Division of Early Intervention and Special Education Services. It is both a pleasure and an honor to be with you here today, and I hope that the information that I provide is informative and helps to answer questions that you may have regarding local education agencies or local school systems. We refer to them as LEAs now. The role of MSDE in this work and how the individual education program, or IEP or IEP team process, works on behalf of students with disabilities and plays into residential placement process for students. In my role here, at MSD, I work very, very closely with all of our local 24 local education agencies, often referred to as LEAs, as I said, as well as our sister agencies, especially those that are members of local care teams, including DHS, DJS, MDH, and the Department of Disabilities. One of my responsibilities is for the oversight of the supervision and direction of the non-public tuition assistance program, or NTAP, for the local education agencies and the non-public special education schools. And that's the program where the state shares in the cost of educating students who are placed in non-public special education schools through the IEP team process. So next slide, I want to take a look at what we're going to be reviewing here today. So, well, first I wanted to share the MSDE mission statement. So under the leadership of our state superintendent of schools and guidance from the Maryland State Board of Education, the department develops and implements standards and policy for education programs from pre-kindergarten through high school. And you can also see our mission statement there. I also want to let folks know that at our last State Board of Education meeting, the board signed a resolution to take transformative action to create a world-class education system here in Maryland. And this new resolution really frames the urgency for bold transformation needed to achieve excellent and equitable outcomes for Maryland, for every Maryland child. So keep an update or keep a watch on our website for more information related to that. Next slide. So as I mentioned, I work in the Division of Early Intervention and Special Education Services, and under the leadership of our Assistant State Superintendent, Marcella Frankowski, our strategic plan was developed. And included in that are the following vision and mission statements for our division. And you can see that all students, including students with disabilities, will be ready for school, achieve in school, and be prepared for college, career, and community living. Our ultimate vision is to close the existing gaps between children with disabilities and their non-disabled peers. And there is our mission statement too. So we provide a lot of support, technical assistance, accountability, leadership, and resource management to our LEAs, public agencies, and stakeholders. Okay, next slide. So as I mentioned, I work closely with county and city local education agencies and our sister agencies. And over the last couple of months, I've often been contacted with concerns and questions related to youth who are in need of a residential placement. Some of the concerns that were being brought my way included the conversations were occurring at the local level, including at local care teams or with local care team member agencies, where local education agencies were being told or just kind of it was being spoken that just change the IEP so this child can be placed residentially. And it seemed that there may be some misunderstandings or individuals that may not have an understanding of the role and the responsibility of the LEA, the federal law that guides the work related to students with disabilities, and how the IEP process works. So another question I often get is, would you send me a list of approved out-of-state residential treatment centers or other out-of-state placements? And the easy answer is that we don't keep a list. And I'd like to share that some information about how the process works, which I hopefully will provide an understanding of why there is no list. And basically, information changes, approvals may change, and so anyway, we'll get into that in a little more in a couple of minutes. And so as I was thinking about how to address these areas, I thought it might be helpful to group our time together into 4 buckets, which you see on this slide here. So we've got local education agency and the local care team, our students with disabilities with IEPs and free appropriate public education, or FAPE, residential placements and IEPs, as well as out-of-state placements and IEPs. So let's jump in. Next slide. Right, so the local education agency and the LCT, the LEA role as an active local care team member really is about referring students and families who are experiencing significant challenges which exceed the scope of responsibilities and resources of the local school system, collaborate with our sister agencies through the local care team process to develop and implement total plans of care, and also to collaborate with our sister agencies through local care team process to identify appropriate supportive community-based services. Next slide. So the next 2 slides that I'm going to share are really heavy with the information that I'm going to share, and due to time, I'm going to try to move through them fairly quickly. Please know your local education agency colleagues, as well as here me at the State Department of Education, are happy to follow up if you need more understanding or information. But I really wanted to take a moment and talk about what a free appropriate public education is, and how that works, how that supports the work of the local education agency. So, as I mentioned, a FAPE, or a free appropriate public education, is what every student is entitled to, whether or not they have a disability. And the key factor for the local education agency and how they work with students with disabilities is through IDEA, the Individuals with Disabilities Education Act, which is a law that makes available a FAPE to eligible children with disabilities throughout the nation and ensures special education and related services to those children. So this is a driver law for services and protection, and it's important, was further validated with that there were no waivers to this during the extended school closure periods with the pandemic. So in a nutshell, for students with disabilities, FAPE is really an individualized education program, the IEP, that is designed to meet the child's unique needs and from which the child receives educational benefit, prepares them for further education, employment, and independent living. This IEP is how we provide FAPE to our students with disabilities who are eligible for special education. Many students with disabilities receive an IEP, which is that written plan for the specific student's special education experience at school. And by law, the IEP must include things like services, progress monitoring, and annual goals, and more. As we look at IEPs and the IEP team process, it really is important to know that throughout the IEP team process, an informed, intentional thought process, and it validates the importance of FAPE through the IEP. And students who receive special education services basically need specially designed instruction. So specially designed instruction, or SDI, means adapting as appropriate to the needs of the student, the content, methodology, or delivery of instruction to ensure access to the general education curriculum through modification so that student can meet the same academic standards as his or her non-disabled peers, and to ensure progress towards meeting IEP goals and objectives. For example, a child with a reading issue might be taught with a multisensory reading program. It includes related services to help the student benefit from special education. Those may include things like speech language therapy or even transportation. And it includes teaching children in the least restrictive environment. As much as possible, students should be learning alongside students who don't receive special education. Placement in a separate class is only allowed if it's necessary to meet the student's needs. And all of these things are reasonably calculated to help students make educational progress. And please know, not all students with a disability, just because a student has a disability does not necessarily mean they have an IEP. So questions that may be looked at to determine the need for an IEP include, does the student's disability adversely impact their educational performance? Does the student need specially designed instruction in order to make educational progress? Is the disability so impactful and adversely impacting that the student needs special education and related services to access the curriculum? And some students, there may be no impacts, or they may not need additional supports. They may need some accommodation. So perhaps the 504 plan may allow better access for them. And that could include things like more time on tests or a graphic organizer to help complete work, but that's not SDI. So it's possible that a student has a 504, then they may find that they need additional support. So then they become to need specially designed instruction, and then they get an IEP. But it's also possible that a student may have an IEP and then it's determined they may only need accommodations. And so now they go to a 504, or perhaps there's no further impact and they don't have a 504 or an IEP. So it's all a very fluid process. Annual reviews or more, if appropriate, happen. There are assessments and evaluations. And I really want to stress that providing the FAPE is the responsibility of the local education agency. And so they facilitate that IEP team process. And the team determines the needs, the goals, the objectives of how the special education and related services will be implemented. Members may include a parent, at least one of the student's regular education teachers, at least one special education provider, a school administrator who can commit local education agency resources, or that local school's resource, an individual who can explain test results and what they mean for instruction. Other individuals, the parent or school system may want to attend because they know that student and have a special expertise about the youth, and often, excuse me. And I also want to point out that starting in 14, the child must be invited to consider transition and post-secondary goals and services needed to reach their goals. As I mentioned, the IEP implementation actually comes down to the responsibility of the service county, and that's where the child lays their head at night, that county where the child is sleeping. And so it's also important to remember that the LEA responsible for implementing the IEP may change, and it's generally based, as I said, on where the student is living. And so that's something I wanted to make sure we pointed out. Also, once the IEP has been developed, we move into IEP implementation, progress monitoring and reviews, as I mentioned, which are held on at least annual basis. And that's to look at and to decide whether the student's achieving their goals and to revise the IEP as appropriate. Let's see, reevaluations are completed at least once every 3 years and look at this at if the student continues to be a child with disability, the student's educational needs, and their present levels of academic achievement, whether additions or modifications are needed for related services and supports, and so forth. IEP teams also determine the LRE, the least restrictive environment, most appropriate for that student based on the IEP and what the school system is able to provide. And our goal, as I mentioned, is to really keep students with their typically developing peers or non-disabled students. So I want to take a deeper dive, a look at LRE. So if we can have the next slide. So placement determination. So the least restrictive environment is the requirement of federal law that students with disabilities receive their education to the maximum extent possible, to the maximum extent appropriate with non-disabled peers, and that special education students are not removed from regular classes unless, even with supplemental aids and services, education in regular classes cannot be achieved satisfactorily. This may, and then we're also going to talk quickly about non-public special education school placements and residential IEPs. So, so when determined, when the LEA determines that they're not able to implement the IEP in a public school setting, The school the child would normally attend, the IEP team may determine that the student needs a non-public special education school placement. So it's important to LRE that LRE may change depending on where the student is placed. For example, if a student is living in Baltimore County with his family, may have an IEP, attending his local middle school, perhaps they become involved with their local social services office and the student is placed in say a therapeutic foster home in Prince George's County. The student's now laying his head in Prince George's County. And so Prince George's County now becomes what we've referred to as that service county. And so now they have the responsibility for implementing that student's IEP. So at that point, that student would be enrolled in the local school and Prince George's County would hold an IEP team meeting and review the IEP. They may determine they're not able to implement that IEP in the public school and may determine that the student needs to be placed in a non-public special education school. Also works in reverse. Perhaps the student has a non-public LRE and then they change where they're living. And then that county where they're living can implement that student's IEP in their local school. And so then they may go back to the public school setting. Again, all of this is a very fluid process driven by IDEA, LRE requirements. And so it's, as appropriate. So you have to understand that there are a lot of factors that play into all of these components. For residential IEPs, questions come to me and to the local LEAs. If a child needs a residential placement, why can't the local school system just change the IEP and make it a residential placement? It's important to know that that's not how the school system responsibility and to place students residentially just because there may be issues at home or that are manifesting themselves outside of the school. Or to change the IEP to a residential IEP to avoid the need for a VPA. Again, there are requirements under IDEA and LRE law, drivers here that really determine the steps, the information necessary to make those determinations, because it's about the educational access for that child. So again, IEPs are how we provide a FAPE. And residential IEPs need to be based on factors that are educationally based. And as we've talked about the IEP and the IEP team placement process, these are grounded, as I said, in the educational impact of a student's disabilities. These are residential IEPs are highly restrictive. They are necessary to provide the student with special education and related services. And it's necessary for the student to receive a FAPE. As we've noted, again, federal law drives this process. It's important to note challenges the student may be experiencing, behavior problems, mental health challenges do not become a basis for a residential placement through the local school system unless they become so severe they interfere with the student's ability to obtain an educational benefit in a typical school setting. And so in those situations, conversations should be held with your local education agency partners, but it's important to remember the process and considerations that are in place that drive this IEP and LRE process. So again, communication with your local education agency is very important, and I can't stress that enough. Okay, next slide.
And hey,
Okay,
Sheila, I just want to jump in real quick. You've got about 4 minutes and there's a couple questions.
Okay. Local care team. So we always encourage our local education agencies to participate actively with the local care teams. And we want to make sure that they are asking families to attend so that we can support the family in the best way possible. So we'll go ahead and just, if you could skip to move to the next slide. And okay. Go back one, please. So again, out-of-state placements, we do have an approval process if the local education agency is placing a student out of state, or if they've been asked to co-fund the educational component of an out-of-state placement. And just please know there is a process where the LEA works closely with me for that. Okay, we'll go ahead and skip to the next slide. I also wanted to just ensure, actually, can you go one more? One more slide. Keep going, keep going forward. I want to get to the home and hospital teaching oversight. Keep going, keep going. There we go. Okay, so I just wanted to quickly, since I only have about a minute left, there is a division, here at the MSD, we have a division of student support, academic enrichment, and educational policy. And they are responsible for, if you go back one, I think, the oversight of our home and hospital teaching. So, and that is driven by the Code of Maryland Regulations 13A 030501. Those regulations establish minimum requirements that apply to the provision of instructional services to public school students who are unable to participate in their school or of enrollment due to a physical or emotional condition. If you go on the Maryland State Department of Education website and look for the Division of Student Support, Academic Enrichment, and Educational Policy, you can find that information. Specifically the Student Services and Strategic Planning branch. Next slide. Okay, so parent or guardian provides the verification of the physical and emotional condition by the appropriate medical practitioner to the LEA. LEA reviews and provides educational services if those services are not already provided by the hospital. And also there is an LEA point of contact for home and hospital, and that information is available on the website. Next slide. And just so, just a reminder, there are some very helpful resources on the MSDE website, especially if you look under the Division of Support, Academic Enrichment, and Educational Policy. They have a frequently asked questions regarding home and hospital teaching that's available on their website. The Division of Early Intervention Special Education Services also has a technical assistance bulletin that is about students with disabilities in home and hospital teaching. But I also want to just let you know there's a lot of technical assistance bulletins, a lot of guidance documents on the DEI SES website. And so I encourage you to Google Division of Early Intervention Special Education Services at MSDE and look for those resources, our publications and information section. And we also have a family services support team that is here if parents have questions about what their rights are and also need additional guidance. Okay, so there you go. That comes to the end of my information. Sorry, I had to go through so quickly.
Thanks, Sheila. So there are a few questions. I'm going to ask you one here. If there would be a concern that the IEP team may not be acting in the child's best interest, what would be the most appropriate course of action?
So if a family member or member of the IEP team has concerns, they can certainly reach out to that family services team here at MSDE in our division because they can help provide guidance related to parents' rights if they have a concern about how things are being implemented or determined.
Okay, thanks. And Sheila, there are a couple of questions it's actually in the chat box starting at about 9:53 a.m. Is it possible for you to go in and maybe answer some of those in writing and we can get to Janet moving on to the DDA presentation?
Absolutely.
Okay, wonderful. So Janet will jump in the chat, or I'm sorry, Sheila will jump in the chat and we'll move on with Janet, and Janet can introduce herself.
Hi, my name is Janet Furman. I'm the Director of Children's Services for the Developmental Disabilities Administration. I've been in the field for well over 30 years and have interacted with many of you, I'm sure. So I want to talk a bit about DDA. I know that sometimes, especially hospitals, get a little frustrated. Our vision within DDA is that people with developmental disabilities will have full lives in the community, in the communities of their choice, where they are included, participate, and are active citizens. And that is for children and adults. In order to do that, our mission is to create a flexible, person-centered, family-oriented system of support so that people can have those full lives. And we're talking about people across the lifespan having the same opportunities as all of the rest of us. Okay, next slide. So DDA focuses on 6 areas. The first is self-determination. The second is self-advocacy. Then supporting families, independent living, employment, and assistive technology. So those are all areas that we do focus on strongly. And next slide. So as far as supporting families, DDA has representatives at each of the 24 local care teams that are available to offer resources to families of children with intellectual developmental disabilities. I do want to say, though, that our representatives at the local care teams are not all well-versed in children's services because they have many other roles. So they will come back to me and ask questions if they don't know. So we do try to give them resources and education, but many of them are carrying on multiple roles. So the LCT coordinator does contact the DDA regional office staff, who's the representative, if the family reports that DDA services are needed, or if the youth is currently involved with the agency. Okay, next slide. Local care team referrals from hospitals are sent to the DDA rep, who reviews them and determines if the child is indeed known to DDA and eligible for DDA funded support services. The DDA representative is to contact the family to determine what services are needed and possibly to begin the person-centered planning process, or to support with helping them access an application and the application process. If they're having problems, their regional director does reach out to me regularly to ask me questions and try to get additional resources. Next slide. So DDA, in one of our efforts to support families, several years ago, developed a family supports waiver. That is a waiver through the Centers for Medicaid and Medicare, a home and community-based waiver. And we offer a variety of support services to children ages birth through 21. And there is a link to the information on our page there. I do want to note that children under the age of 21 in this waiver are not able to access residential services. This waiver is simply support services, but the idea is to try to support those families before they get to a point of crisis so that they can remain in homes and remain in their communities and just access these support services. So next slide, please. So this is a list of the support services. It's pretty extensive. I'm not going to read every one because you'll get a copy of this. But if you can see, we offer some assistive technology. We offer behavior support services, environmental modifications, housing supports, personal supports, which is an in-home service. Respite care is a service that's used pretty significantly. And then some other services as well. Next slide, please. So I want to talk about DDA eligibility, and I just saw a question come up about whether it just was brief, but DDA does not work through Optum. You must apply through the DDA application to the DDA regional offices. We do accept applications for people at any age or time. I do think in services, we have someone as young as 3 right now receiving support services. And we do ask that families try to submit applications around age 14, if not before. And we try to catch, at least at age 18, those students who will be transitioning from the school system, but people get missed. And if the child is not in the school system for some reason, then we don't necessarily know about them. So if anybody finds out about families that have kids or adult members with intellectual developmental disabilities, please feel free to encourage them to submit an application. Submitting an application, you complete questions on the application, but also need to submit supporting documentation. And what supporting documentation is: assessments. It can include an IEP. We like to see functional assessments if possible. The IQ is not the only thing that we look at. We really try to look at how the individual is functioning. And a lot of times people submit psychiatric assessments, which is fine, But if that's the only thing submitted and the psychiatrist has only focused on the psychiatric diagnoses, then it is likely that the child will be found ineligible. So we need to see something that actually indicates a diagnosis of intellectual developmental disability. And if you submit things and are ineligible, you definitely can resubmit other information and ask to have a reconsideration. And there's also an appeals process that is sent out when the denial is sent. But I also want to stress that eligibility for services doesn't mean that we're able to provide funding right away to address those needs. And I saw another, we do have a waiting list, and we also have a future needs registry. And those that are prioritized for services are people who are in emergencies or crisis resolution, meaning that the crisis will impact them within the next couple months. And then when kids are transitioning from the school system, they are prioritized, and kids that are transitioning from the Department of Social Services into DDA adult services are prioritized. So when that designated funding for the priority category is available and the child has the greatest need, their coordinator of community services, case manager, will be informed and will assist with the DDA waiver application process. That's also another confusing piece, is that there's actually two application processes. One is application just for eligibility. And then once you've been found eligible and prioritized for funding, you would need to submit an application to get into the DDA waiver so that you can receive services. DDA currently only provides services to those people who are eligible through the DDA waiver process. And again, DDA services are provided based upon eligibility, priority, and availability of funding. Next slide, please. Here's a list of our regional offices, the counties that they serve, and their phone numbers. I will tell you that not everybody is in the office yet, so it may take a little bit to actually get a response back if you call the number, but you will get a response back. I do also want to say DDA, we are not set up to deal with emergencies in a quick time frame, because we do utilize the funding through the waiver that has to go through several different people to be processed. However, we have worked with many urgent situations and with many hospitals. We cannot force one of our providers to take somebody. And I will tell you that DDA licenses a number of children's residential providers. DDA does not provide residential services for anyone under the age of 18, but our residential providers for children are contracted with either local school systems, the autism waiver, the Department of Human Services, and some of them take out-of-state children as well. As you might imagine, children who go into DDA residential services tend to not leave. So once they have taken a bed, that bed is generally not going to be freed up again for a while, which means that we are constantly having to develop more capacity. And with the current needs that we're seeing in kids, we're trying to also develop more skills for our providers so that they are more skilled in working with some of these kids who have really, really challenging behaviors. We do continue, and I work closely with all of the members that are on here, but especially with the Department of Human Services, to really look at capacity and what is needed. We try to address the trends we're seeing. We can't always make it happen, because any of my providers must go through a licensing process before they can be able to take anybody. And I'm trying to think, I think that's really, I mean, we do want to support people. You're definitely welcome to contact me if you're not having any success with the regional offices. I do know that there have been some situations recently, both children and adults, where we really haven't been able to find appropriate placements for kids. So next slide is my contact information. Right now, I am working much remotely. You can utilize my cell. Email is the best way to get me, and we can always set up a time to talk if we need to do that.
Great, thanks, Janet. A couple of questions for you. What do you do if there are no providers in your area for children, providers for family supports waivers?
We are constantly trying to develop those providers. In fact, I had a conversation with a potential provider last week. I have one next week. We're constantly trying to develop new providers from other systems, from other states, just brand new providers who want to come on board. We also, as I said, we're working to try to develop more skill capacity within our current providers so that they feel more confident in serving these kids who have multiple diagnoses and are really a little bit more of a challenge than the typical kids that came through the system 20 years ago who had intellectual developmental disabilities.
Yeah, and that question came out of Western Maryland. I know for sure it came out of Allegheny, so I don't know if we have, if we're working on services or if we have a provider net out there in far Western Maryland.
So I would recommend contacting the Western region. And I think actually I saw that our provider services director for our Western region office is on this call. So I know he will take this back and he will look at the services that are available out there. And but you can always reach out to the Western region office, or you can reach out to me and I'll end up reaching out to the Western region office.
Okay. Next, given that DDA doesn't place children residentially, are there any options for parents of children in need other than placing children in foster care?
So there are other options for children. And I don't want to speak on all of them because they're not under DDA. Sometimes the local school systems will determine that a child needs residential services. Sometimes the family can work with the local Department of Social Services. And I can offer more specific resources knowing a specific situation, but I can't give you a big general answer.
Sure, and I'd add to that as well that, you know, the answer, simply because DDA doesn't have access to, you know, residential placements for children, doesn't mean that the alternative is to put that youth into foster care. That there are other options, and going into, you know, what we're talking about today, going into your local care team and sitting down with all of those folks at the table to see what options are out there. And that we don't want folks to feel like, well, the only place we can go is essentially to put our child into foster care. That's not the direction, you know, we'd like to try to go in. So forming these interagency collaboratives where everybody can come to the table and see what resources their agency can provide. You know, hopefully we can then change the trajectory of that case. And
I think also, Jenny, trying to encourage families before they get into crisis to really look at our support services and other supports that are out there for them can really help. Once you're in crisis, it's hard to think about anything else. I understand, but
yeah, Jenna, and you speak to that frequently, that, you know, by the time a parent gets to DDA, it is at that crisis level a lot of times. And so if we can let families know that there are services out there before it gets to that point, that, you know, it could change the trajectory of the case.
Yeah.
Another question, are there caseworkers that help people apply for services?
So we have coordinators of community services who are contracted to work with DDA to do the eligibility assessment, our comprehensive assessment, and then they provide ongoing services for people once they've been found eligible and at different priorities. There are not any, but there's nobody specifically identified to help with an application, but it can be done by anybody that knows the family. It does if the family needs help. If it's a hospital social worker, if it's a neighbor, a local a school system person that they've been working with, anybody that they know and they're comfortable with. And definitely you can contact our regional office to ask any questions that you would have.
Okay, it looks like one last question. What outreach is being done to ensure these parents are getting to DDA services preventatively rather than waiting until emergencies? And we've talked about this, Janet, about all the training that gets done by DDA, but you can elaborate on that.
Right. So, I mean, we do a lot of training recently. We, our regional offices train all the time and share information all the time with families through local school systems, with families in just in the community at large. We also, recently we did a training for the National Institutes of Health through Adventist, talking about services to children and transition. And we are always available to go out and do presentations. Another thing I do want to mention that I didn't put in here is that we do also offer what is called low intensity support services, which is a program that families can apply to. They take applications twice a year. You're eligible once a year if you become selected for up to $2,000 for some identified services such as specialized equipment, personal support, respite, those type of things. So that is another option. It's done by random selection, so you never know if you're going to get that, and it's not going to deal with a crisis unless your crisis happens to come right at the end of the application period and you get selected. But it is just another option for families.
Thanks, Jenna. We're almost out of time, but one more. Are community pediatricians aware of all these services? Do we do any kind of outreach there?
We have not recently done any outreach with community pediatricians, but that is something that we can put on our list to do. That's a great idea. Thank you.
Yeah, we appreciate that. Okay, thank you, Janet, so much. And we're at time, so we're going to jump over to Kara Annenson. Kara's with the Department of Juvenile Services, and I'll turn it over to her and she can introduce herself.
All right. Good morning, everyone. My name is Kara Annenson. I am the Executive Director of Resource at the Department of Juvenile Services. I am very excited to be with you all this morning to talk a little bit about DJS and our role in placing kids and our role in the local care team. Additionally, we had a big legislative session this year, and there have been some major changes to the system that are going to affect June 1st. So we have been busy over at DJS trying to implement these new changes. So I'm going to fold some of that information into this presentation. And then when I'm done, I'm going to put in the chat a link to our website where there'll be documents that help explain some of these changes in a lot more detail. But I did want to make you all aware of this because I think it's such an important time to be talking to both the hospitals and the local care teams, because we are going to be seeing some changes to who the department can serve. And I think that this just is so important for collaboration to work with those young people that may no longer be able to be served by our system. So the Department of Juvenile Services, this is our vision and our mission. You can go ahead and go to the next slide. The Department of Juvenile Services is a statewide system. We are broken up into 8 regions. That is a new change. We weren't always in these 8 regions. That actually happened about almost a year ago now. And so we kind of reshifted our region system to more align with the court system. And so this is an updated map that shows the new regions. We operate detention centers. We operate 6 detention centers throughout the state. And that is where young people go. We'll talk a little bit more about that. And the other thing that we do is we operate programs, committed programs for young people once they've been adjudicated, found delinquent, and the court has ordered them to a level of treatment. We operate detention centers committed programs throughout the state. We have 2 youth centers that are out in Western Maryland, and then we have Victor Cullen, which is our hardware secure facility where we place young people. So you can go ahead to the next slide. So the department is serving young people who come in contact with the law. And so there are a few decision points throughout the departments or throughout a kid's flow in the system where we're able to make decisions and make recommendations to the court. And so we're not the ultimate deciders in what happens. The department makes recommendations to the court, and then the court is the ultimate decider as to what happens in these cases in some instances. So we're going to first start out talking about intake. So that is when a young person comes to the attention of the department and they're in the community. And at that point, the Department of Juvenile Services has the ability to pre-court supervise kids, put them on get them services in the community and monitor them. And if everything goes well, we can close their case. This is where I want to talk about a little bit of the changes about who can come into the Department of Juvenile Services. And so in the new law that was passed, the juvenile court jurisdiction age limit changed. So now young people under the age of 13 are no longer allowed to come into the Department of Juvenile Services. However, there is a caveat. So young people who are 10 and older and charged with a crime of violence are still allowed to come into the Department of Juvenile Services. So that's a shift. Originally, but prior to this legislation, young people as young as 7 could be involved in our system. So this is a change that now those young people, the door is closed, they cannot come in to DJS. And this is probably where we're going to have to leveraging some resources through the local care teams of how to work with those young people that are coming to the attention of the police. And so at intake, we make a decision of how to move forward. We can forward the case to court. The other way that a young person comes to our attention is if a police is requesting detention for a child. And if that happens, we have intake workers that do what's called a DRAY, a screening tool to determine, should we continue to keep this kid detained? Are they going to show up for court? Are they a risk to public safety? Those are the questions that we look at when we are using our validated risk assessment tool to make that determination. And we can do a number of things. We can return the kid to their family, put them in the community, put services around them, or we can continue to detain them. However, with the new law, youth that are charged with misdemeanor are no longer going to be allowed to be able to be in detention. So that is a change unless it's a handgun violation. So that door is going to be closing for those young people who are in that category of offenses. However, the department can still make the recommendation if we decide to continue to detain a kid, a young person, then that kid goes to court the next day, and then the judge can make a decision on whether or not to continue that detention or to release the kid in the community and put them in alternative detention. So there's we have ERCs that we operate throughout the state. We have electronic monitoring, we have GPS, or the kid could just be released to their parents. So those are kind of the options around detention. And then if the kid continues in the court process, we have an opportunity to make a recommendation for what should happen if they're found guilty, which we call adjudicated delinquent in the juvenile system. We come up with the treatment recommendation. We're going to talk a little bit more about that in some other slides. So I'm not going to go into that now, but I do want to note here that there is another change brought by the new JJRC law that talks about what we can do at disposition now. So if a young person is charged with a misdemeanor offense, they're no longer allowed to be committed to an out-of-home placement. So they're no longer going to be able to go into those out-of-home placements. They're going to be served in the community. So that is just something to keep in mind as we're all working on implementing this new legislation. And then reentry. So that's when a young person is leaving a treatment program and coming back to the community, then they're on some level of supervised probation. And one thing I wanted to mention here is that the Maryland General Assembly also made changes to what probation looks like. And so now for a kid that is charged with a misdemeanor offense, probation can last up to 6 months. and can be extended in increments of 3 months. But that's only if the youth needs to continue, if there's good cause and the youth needs to continue in treatment programming. If a young person is charged with, or their most adjudicated offense is a felony offense, nonviolent felony, probation can last for up to a year with the ability to extend. And the crimes of violence, kids can still be on probation indefinitely, just like they are now. So those are some major changes to the system. And I know we are all going to be working through this and having a lot of questions, and things are going to come up. And so we want to make sure that we are a resource for you. There'll be a lot of information on our website. And like I said, that will be, I'll post it in the chat. There are going to be questions, cases are going to come before us, and we are ready and willing to work with you and talk through these cases, right? I have been living with this now since session ended, and there are still circumstances that come up that I have to talk through. I'm like, okay, how old is the kid? What's the offense? How are we going to do this? So, that is what's going to happen, and we'll work through it together, and we will, make decisions and come up with solutions to make sure that kids are getting what they need. So you go ahead to the next slide. So I just really wanted to highlight here about how the department recommends to the court about the level of care that a youth needs. So we have the ability to say to the court, this is the level of care that the young person needs. And then the court is the one who makes an ultimate decision on what the level of care the department should provide. And then we find the program to match that level of care. And so depending on where the youth is in the court process is going to kind of determine who the hospital is working with, who the local care team is working with, because it really depends on what level of involvement the department has. So if a young person has an intake, you're going to be working with an intake worker. That's kind of a case manager, but they're focused more on the intake work. If a young person is in detention and is brought to the hospital, because they're in the hospital, you're going to see our transportation staff there, because we're going to continue to monitor that kid while they're in the hospital. And then for young people that are on probation, you're going to be working with their case manager, and that's after a young person has already been adjudicated delinquent. So there are different people that you're going to be working with. I am always happy to be a point of contact if you're having any issues dealing with any of the staff of the Department of Juvenile Services. My information is going to be on a later slide. You can always reach out to me. I'm happy to troubleshoot, figure out who you need to be talking to, and help deal with any issues that you are experiencing. So you can go ahead to the next slide. So I just wanted to talk a little bit about how we make our level of care recommendations to the court. And so we hold what's called the multidisciplinary staffing team. And you can see all of these bubbles around this recommendation slide, because we look at many different factors when we're talking about what are we going to recommend to the court. We ask the young person what they think and what they believe their needs are. We talk to the family. The family is included in the meeting. They talk about their needs and what they think would be best for their child. We do skills assessments. We talk to other agencies. If the youth is has some involvement with with the local DSS, we'll invite the DSS staff to be there. We look at what's their prior history. Have they run away from other facilities? What's kind of that history? How, do we need to put them in a more secure facility? We look at their somatic health, the behavioral health reports that they have. If they've been in a facility before, we look at their MCAS, which I'll talk about on the next slide, but that's a validated tool that we use to help us determine a young person's strengths and their needs. We look at their education needs. We do a substance use assessment. We at the department do our own psychologicals and psychosocials, and the people who did that are part of the team to help us have that conversation. We look at any old evaluations, any other services. What has the youth been successful in before? Have they had any other prior adjudications? What's the permanency plan? What is this young person's ultimate place going to be after they're done with our services, because our services are finite, right? Because we're really looking at how do we understand that this kid has been adjudicated of offense, mitigate that, and then put them back into the community so that they can be successful. And then any other specialized assessments that we need. Is there something going on with this kid? Do we need to have a psychosexual evaluation, a neuropsych? What's going on with this young person? We'll get all those evaluations done. We'll come together as a team. and then we will make a report to the court to consider when they're determining what level of care to recommend. And again, that goes to the court. There's, all the other parties at the court, the public defender or the child's counsel, the state's attorney, everyone makes their argument, and then the judge is the one who makes an ultimate decision. So you can go ahead to the next slide. So I just wanted to touch base just briefly on the MCAS. This is our tool that the department uses. It is a evidence-based screening tool that helps the department make recommendations and help us to determine risk level, supervision level, and then helps us create our service plan. So every young person that is either going to be on probation or is going to be recommended to an out-of-home program gets this assessment, and it's the tool that we use at the department to help us identify what are those youth needs, what are their strengths, and how can we best serve them? Was that with an evidence-based service in the community, or is that a recommendation for an out-of-home placement? You can go ahead to the next slide. All right, this is just a little bit about the level of care that the department has when we're talking about out-of-home placements. So we have the traditional foster care, we have group home, therapeutic group homes, independent livings. The next level of care that we can recommend is what we call a level 2 staff secure residential. Those are also group homes. How I like to think about these are group homes that are school on ground. So a young person is not leaving the program to go to school, they're on grounds. So we think of our youth centers that have on ground schools as a level 2 staff secure residential because they are getting school there. They're not going anywhere else. Residential treatment centers, and then, like I said, our treatment programs, the youth centers. And then we have hardware secure residential services. So we do have CTC, which is a hardware secure residential treatment center that's located on the grounds of Hickey, which is a program that we can use there. And then hardware secure treatment program that we operate, which is called Victor Cullen. Additionally, we do have contracts with other programs that are located out of state, but we exhaust all in-state resources prior to using those out-of-state services. But we do have those contracts available to us. And then I think the next slide is my information. So I did see some questions in the chat, Jenny. So I don't know if you have them up or I could pull them up.
No, I do. So two of the questions apply to the new law, and but let me start here. So for patients with DJS involvement, what part does DJS play in placement for patients stuck in hospitals that might also have DSS involvement? So talk that dual agency involvement with DSS.
That's a great question. And so, one thing I want to mention first, and I'm sure Tennille will probably also talk about this, but the collaboration that we've been doing on the local levels with our crossover youth practice model, and really working to make sure that we are partnering as agencies to make sure that families aren't getting two different messages from two different agencies saying, here, DJS is saying you're gonna have to do X, Y, and Z, and the local DS is saying you need to do A, B, C. So we're really working together a joint case plan on those cases. And as far as placements go, or what is DJS's responsibility if we're involved, we should be working together with the DSS and being able to avail the youth to all of the services in both agencies. So, when those cases come up, we will work together and help identify programs and placements for that young person that sometimes maybe we have contracts with that the local DSS might not. And so the expectation from our agency is that we will be working with the hospital and the local DSS to make sure that all of our placements are available as well. Oh, I do want to just have one caveat to that, Jenny. It depends, because if the youth are committed to our agency, so we cannot, if a youth has not been adjudicated delinquent yet or found guilty, we can't place a kid. That doesn't mean that we still can't find creative ways to help leverage our services that we have and help with our contracts, but we can't actually place a kid unless the court has found a young person adjudicated delinquent and then made a recommendation for a level of care.
Yeah, and this goes into the larger process of listen, you've heard today all of these different agencies and the different policies and procedures that are in place, but understanding how much of a priority we're placing on collaboration and communication between each other to make sure that if our agency has access to a service that's going to help a youth, that we are actively involved and engaged in providing that, regardless of, who technically, is assigned, that we're trying to work together to create the best outcomes for youth. So the next question is, given the new law that narrows the eligibility for DJS services, logically, at least at some level, these youth will migrate to DHS. How, if at all, has that agency been resourced to respond to the increase in need? Now, I don't know that this is as much a DJS question, but what I would say is we've seen decrease in placement from DJS since the pandemic, and that has not at all seen an influx into DHS. And so the focus here is the building of community-based services to keep kids out of residential placement. So Carrie, you can chime in, but I don't know that that is as big of a concern in terms of this huge influx that DHS may see. I haven't seen that, but you can comment.
I 100% agree with what you just said. We have been seeing the numbers over the past 10 years decrease dramatically and have not seen an increase. So I agree with you, Jenny.
Okay, what new community-based services will be available July 1st to meet the needs of children who can no longer access more intensive DJS services? Please provide a specific list of new resources and programming.
So there will be, I'll put the link in the chat where all of our resources are located. We have been working at DJS. During the pandemic, we really started working on it with courts taking a long time. It's moving all of our services that we offer to young people kind of at that probation stage to the front end of our system. Why are we waiting for a kid to get all the way to probation, right? They've had to go through the whole court process, but we can offer them at the beginning. And so we have really migrated all of our evidence-based services, all of that stuff, and moved it to the front end of the system and made those services available for kids without even court involvement while the department still is paying for those resources. So, there's not onboarding new resources, but that's kind of where we're at.
Okay, and I do have another question. I'm not sure if DJS can issue an opinion on this, but, do you think there needs to be a curfew in Baltimore City, especially going into the summer, considering there's been no reduction in violence in the city for years?
What I will say to that is, when you look at the data, and we'll put the data on is that what we really are looking at is it's not young people that are committing these horrendous crimes. It's really those young adults who are 21 to 28. And I think that kids often get blamed for that. But when we look at our data and who's coming in our front door, it's not those cases. And so I know that that's sometimes a hard message to hear, but that's what we are seeing at DJS.
Thanks, Kara. I know we have some other questions, and I think what we're going to plan to do, we're going to take all of these questions afterwards. We'll put a document together, make sure it goes out to everybody so that we answer these questions. I just want to make sure that we get to Ms. Thomas, and Tennille Thomas has time for her presentation. So go ahead, Tennille.
All right. Good morning, everyone. My name is Tennille Thomas. I am the Deputy Executive Director for Placement Services and Performance Monitoring with the Social Services Administration under the Department of Human Services. While we only have 20 minutes, and looking at the questions in the chat, I think I'm going to cut the presentation short, Jenny, and try to answer some of the questions from the chat. So that I can make sure that we get the most out of this time. As you all know, DHS is the state's primary human service provider. We have 24 local departments that assist youth and adults. And so under the Social Services Administration, we provide prevention services, protection services, preservation, placement, and permanency services. In addition to well-being adult services, we have an operations department, a continuous quality improvement department, and that includes our practice innovations. Next slide. The strategic direction for social services administration really is geared towards ensuring that children, youth, and adults are safe and free from maltreatment, have access to a full array of services, are able to thrive in their families, are working with well-trained and competent staff, and just ensuring that they are have healthy and resilient and stable, lasting family connections. Next slide. The front door for the Social Services Administration and the work that we do is our protective services. And that protective services is not just for children, but for adults as well. Those CPS units or APS units are responsible for promptly responding to allegations of reports of abuse and neglect and informing individuals about the roles, processes, and expectations, conducting quality, risk, and safety assessments, determining what services or plans for care are required to support the families, as well as protect the child, youth, or vulnerable adult, as well as initiating services as appropriate to promote safety, reduce future risk, and remedy past abuse or neglect. Next slide. In addition, family preservation services and foster care services, also known as out-of-home care. So the family preservation services, again, support families to enhance a caregiver's ability to create a safe and stable home and preserve the family unit, and is intended to be short-term and family-focused to best assist families, particularly in a time of crisis. Our foster care is short-term, we hope, and to support children and families. It's designed to build strength and resolve problems that cause the separation, and ensure that children may live with relatives, primarily kin or fictive kin, unrelated resource parents, or settings such as group homes, residential care facilities. We don't really use emergency shelters or supervised independent living. Next slide. There are several types of placements that are utilized through the Social Services Administration and our local departments of social services. The first form of out-of-home care that we want to utilize is kinship care. We'll also use our regular public foster care. We can do trial home visits when it's determined that a youth is ready to return home. Youth are able to receive services through our group homes, which include traditional group homes, high-intensity group homes that are licensed by our department under the Office of Licensing and Monitoring, therapeutic group homes, which are licensed by the Maryland Department of Health. We utilize group homes that are licensed by the Department of Developmental Disabilities Administration. We utilize adult group homes for those youth that are 18 and over. So there's an array of different types of group home services that are provided to youth who are identified for out-of-home services. We also utilize treatment foster care through our private agencies and the highest level of care, which is a residential treatment center. Next slide. So the questions asked, I believe, Jen, were really regarding the roles. And what are the roles of the local departments versus the roles of the central office? So in the central office, which is SSA, our role is really to assist the local departments with any of the policies and practice needs. We establish policies for those local departments to carry out those practices that you see during the day-to-day operations. We're also tasked with assisting and coordinating with discharge planning with other state agencies such as MDH and DJS through our partnerships with other state agencies. So that is, it's a formal role that encompasses a lot from our central office, as opposed to the local departments. And their role is really directly working with our youth that are in the care and custody of the agencies. They would be responsible for communicating with the hospital regarding discharge planning. The workers are responsible for attending the treatment planning meetings, coordinating with families, and just carrying out the day-to-day operations as it relates to transitioning that child to the most appropriate placement. Next slide. Contact information as it relates to the local departments. Hospital staff, when they are working with a youth, should contact the child's case manager. There is a chain of command as it relates to the case manager, the supervisor. There's also program manager staff. There's an assistant director and a director for each local department. However, at SSA, there is a placement services team that is assigned and can be utilized if there is ever a need to reach out to SSA regarding any barriers that a hospital staff is experiencing. Myself as the Deputy Executive Director, there's also a placement supervisor, Deborah Lynn Pearson, and a placement analyst, Sheila Garrett. Agency involvement. So the local department is responsible for communicating with the hospitals regarding a youth treatment, as I indicated earlier. If there's a multi-agency, which means DJS or DJS, there should be a collaborative teaming effort utilized in order to provide services to that youth. When a youth is co-committed to both DHS and DJS, costs for the youth placement are split between both agencies. However, we do coordinate on the placements to ensure that it is the most appropriate placement for that youth. If a youth is under a voluntary placement agreement or a family is seeking a voluntary placement agreement, that agreement is initiated at the local department level. Next slide. And this is the big question, the voluntary placement agreements. So voluntary placement agreements are initiated by a family member, and that family member, in consultation with community partners, stakeholders, et cetera, have determined that there is a need for a youth to receive a higher level of care or residential intervention that cannot be provided in the home. The VPA is utilized in most terms for youth to receive care in a residential treatment center, a group home offered by DDA, or a diagnostic placement. It is determined to be short-term and not a long-term, and the goal is for that child to return home to their parents. DHS would be funding that residential service. The child, it would not be under a center agreement with the department. Again, DHS would be funding the agreement. The child's goal is to return home to the family. I have attached to this presentation the VPA policy as well as a fact sheet that answers a lot of questions regarding the VPA practice. As it relates to a VPA, if a child is determined to need placement out of state, a Icpc must be obtained. This is an approval from the receiving state for that child to receive services in the state. Maryland would submit a request to the receiving state for that state to approve the youth coming into that state to receive services. Types of placements covered under our Icpc are preliminary for adoption, foster care placements related to resource homes, group homes, or residential treatment facilities, relative kin placements, and placements of adjudicated delinquents in institutions. Next slide. When does the ICPC apply? Again, it is when a child that is under the Maryland court's jurisdiction, order of protective supervision, order controlling conduct, shelter care authorization, or commitment status or guardianship to an agency. The natural parent or non-agency's guardian rights regarding the child have been limited or restricted by a court order, or usually to ensure the child's protection, and the child is proposed to be placed across state lines. When does ICPC not apply? When parents placing child across state line where the LDSS does not have care and custody of a child, or when placement in a medical facility for an acute short-term illness or treatment is determined, placements in an educational institution or boarding school, or placements with non-offending parents if court terminates jurisdiction at the time of placement and the custody transfers and does not require a home study. So as we've indicated, I think along the lines of this whole presentation, we partner with several state agencies, but this slide really speaks to the partnership with DDA in utilizing their autism waiver and the family support waiver, as well as the TAY program with BHA. And again, my name is Tenille Thomas, and I'm the Deputy Executive Director for Placement Services with SSA.
Okay, thanks, Tenille. We have a few questions, and actually, now that we're at the end here, I may throw them, if they're not necessarily applicable to Tenille, I want to make sure we try to get to as many as possible. Well, here's a DJS one for youth charged with a misdemeanor. So Kara, for youth charged with a misdemeanor charge before June, will they be under the new reform or under old policy due to change occurring before June?
They will be under the old policy, but that doesn't mean that people aren't going to make arguments saying that this was the intent of the court. But we are moving forward as if the offense happened prior to June 1st with the not using the new legislation. It's not retroactive.
Okay. It seems that, so Tenille, we can all pretty much answer this. It seems that there's an overall lack of placement resources across the state. What is the state doing to help with so many children who are, quote, stuck?
I couldn't hear you, I'm sorry.
So the question is, it seems that there's an overall lack of placement resources across the state. What is the state doing to help with so many children who are, quote, stuck? You know, Tenille, you can take that, but I will too. There are so many things that we are attempting to do to ease the clog within the system, and having folks understand that this is not just a clog within hospitals, but it sort of is down the chain, and building up those resources, you know, at the RTC level, at the group home level, as well as the community-based level, are all things that the state is focusing on in order to improve, you know, the system overall. There's a hospital overstays plan that was put together by the Children's Cabinet. This directive number 3, which deals with local care teams and partnering with the hospitals, was one very direct link in trying to help with that resource and placement clog that we are seeing. So the overall goal and point of this webinar is to get folks to understand that, you know, we at the state level are working very hard in a collaborative and interagency way to address the concerns that we are hearing about. And local care teams that are sitting in every single jurisdiction, they are essentially the interagency body that, you know, sort of relates to what we're trying to do at the state level. And they are the folks with the expertise and the knowledge of the resources in every single jurisdiction. So we are doing a ton of work to address that. We have put out, MDH has committed a tremendous amount of funds to specialized resources. There was just a statement of need in an RFP that DHS put out late last year, seeking respite and diagnostic beds. So there is an active effort going on to build the placements that are needed. Let me see here. Tennille, I don't know if you want to, if you want to jump in, or if anybody wants to jump in on that.
Sure. So as it relates to, and there's a swarm of questions. So as it relates to processes, as Jennifer stated, there's a collective effort on all state agencies to address the hospital overstay crisis. But it's not just a DHS issue, it's an MDH issue. It's because of the placement resources available. There are staff shortages in our current providers as it relates to just not having the staffing to really attend to youth. And we are working with our provider community to help them address how they can obtain staff to address the shortage. MDH was able to identify a provider to have beds available for overstay while youth are awaiting transitioning to placements. There are 6 beds that are available for that program, and there are additional beds coming online to address hospital overstays. So there is a collective effort across the state in working to reduce the overstays that youth are experiencing.
Okay, Tennille, is there any way to expedite the process of interstate compact and SSA involvement in this process?
So I'm not sure where that question is coming from. Their interstate approvals are really not a lengthy process. An approval from another state can take between 2 to 20 days, depending on the type of placement that is being sought. If it is a residential treatment center referral, that approval usually takes between 2 to 3 days. Now that approval is only good for 30 days, and it is dependent while the Icpc approval can happen, the facility that has approved that youth may not have a bed available at the time that the Icpc is approved by that state. So the Icpc approval times, again, range between 2 to 20 days, and it is dependent on the type of placement that is being sought.
Okay, again, Tennille, the family may be requesting a VPA, but unable to take the child home from the hospital due to reasonable fear of harm of the child or other family members. This creates a challenge as the hospital does not have any other discharge plan and respite services seem to be unavailable to the family. What strategies are available other than finding a concerned parent to be neglectful and placing the child in DSS custody, who also has no appropriate placement resources until the RTC placement is available?
And that's a question from Jane. So I'm not sure if that's a DHS question because they're working with us and we are trying to mitigate those factors so that you don't have to come into care, because again, the goal of the VPA is for the child not to come into our care and custody. If we can prevent a child from coming into our care and custody, we will do so. So it's really having to identify if the child has a recommendation for RTC level of care, identifying additional resources for that level of care.
Okay. All right, thanks, Tennille. Listen, everyone, we are at time and a little past. I know that there are questions within the Q&A as well as the chat that we haven't been able to get to. So my intention here would be to take the questions as I indicated. This is being recorded and we will be posting it. We'll send you all the necessary information. But we'll put the questions together in a document and make those things public just so that we make sure we're answering all these questions. And if you have any other suggestions, about topics, from an interagency state perspective that you all would like to be involved with or you all would like to hear about, please feel free to let us know. We really appreciate your time and we hope that this was helpful today. Please feel free to reach out with any further questions. Thank you, everyone.